Hello, my dear friends, my dear colleagues. This is a live demonstration from Nanjing First Hospital, China. I'm Dr. Junjie Zhang. Today, in the next 2 hours, there will be 2 live demonstrations from our CAS lab. All left main bifurcation lesions with a severe calcification. This is a CAS lab 4. Let me introduce the first case. And the first case operator is Dr. Ye with his team. So please, Dr. Ye, introduce your team and your case.
Thanks very much. This is transmission from Nanjing First Hospital. I'm Dr. Fei Ye from Nanjing First Hospital, and today we will perform a case of this left main bifurcation lesion. And my sister is Dr. Li Xiaobo from Nanjing First Hospital and Liu Shuiyuan from Nanjing First Hospital. So, Dr. Li Xiaobo, would you please introduce the introduction of the patient?
Please show the slide. Next. Good morning, everyone. It's my honor to introduce this patient's clinical history. He is a 75-year-old male, testing for 9 months and aggravated for 1 month. His risk factors of coronary heart disease is hypertension, diameter, and current smoking. He have a normal renal function. BNP is 381. ECG showed pathological Q wave in inferior wall leads, depressed SD segment and involved T wave in anterior wall leads. UCG showed abnormal inferior wall motion, and left ventricle ejection fraction is 53%. Clinical diagnosis is unstable angina and older inferior myocardial infarction, hypertension, and diameter. Next. This is ECG. Next. From baseline CAG of RCA, we can see the stent implanted last year in proximal RCA is okay. Next. This is baseline CAG of our left coronary artery. From code view, we can see distal left main and the proximal LED circle is a true bifurcation, and the median type is 111. Distal segment and the proximal segment of a circle have severe stenosis. Proximal LED is very severe stenosis, and the lesion is severe calcified. From RAO cranial view, the distal LED and the middle LED is okay. Proximal LED and the diagonal one is a true bifurcation, and the lesion of a diagonal is very diffuse. Next. This is the AP cranial. From spider view, the distal left main true bifurcation is showed very clearly. Next. Before PCI, we calculate the risk stratification routinely. Syntax score is 28, and the syntax 2 for PCI, 4 years mortality is 5.1%. For cabbage is 10.9%. According to the definition criteria of Professor Chen, the distal left main bifurcation is a complex bifurcation. Next. Before PCI, we checked the QFR of LED and the circ. QFR of circ is 0.63. LED is 0.58. Next. Okay, for this lesion, our stent strategy is the PCI will be performed by support of IBP. For the distal left main bifurcation, we will use DK crush stent technique, and the IVUS will be used to guide this PCI. If necessary, shockwave will be used for the calcified lesion of proximal LED. Thank you very much.
So from the angio, we can find the severe calcification at the proximal part of the LED. And we also find some calcification lesion located at the proximal circumflex. So how to treat this kind of situation of the complex bifurcation lesion based on the angio? For the patient who has a restless chest pain right now, and we also find the unprotected distal left main bifurcation lesion for the left, even though the EF value was normal, but we also know the EF value calculated by methods, not the Simpson method. So we don't think it's correct for the patient. And we also find that maybe necessary is maybe IABP is necessary for this patient just because this patient has with unprotected left main complex bifurcation lesion.
Yeah, for this case, actually, this is the previous old MI, inferior MI cases. And recently, one mouse readmitted with the rest chest pain. And so, and also you see today's morning's corneal angiogram, it's a typical distal left ventral bifurcation lesions. And also the baseline of the LID flow is a little snow, maybe a TME2. So considering, I fully agree with Dr. Ye's option for this typical unprotected left man, we should use IBB support. Although this patient LEVF is 53%, but you can see RCA is in fact already with hypokinase inferior, considering left side is the critical lesions. I think with IBP, I think for this case is suitable. So for this particular case, just as you mentioned and Dr. Lee introduced, it's a typical complex bifurcation lesions. Circumflex lesion length is longer than 10 millimeter, and with in terms of main vessel LAD to left main is a long lesion with severe calcifications from these AP caudal views. So I think according to the definition criteria, I think according to the definition 2 trial, 1 year and 3 year result for this kind of complex lesions, 2-stent technique, especially with the decay crush, where resulting favor long-term follow-up. So for this case, Dr. will you use intracorneal imaging guidance? And if you use, you will choose IVUS for OCT for this particular case.
Yes, very, very good question. And for this case, especially for the with my old myocardial infarction of inferior wall, and we also use IBP support for the whole procedure. For this case with left main bifurcation lesion, I think IVUS is the best choice for this case. Another reason is for the maybe OCT, we will use a large volume of the contrast during the OCT checking. So I think IVUS is my first choice for this case. Another question is if we want to perform IVR for the proximal LAD calcified casing lesion, we don't know the calcification thickness just because IVUS cannot measure the thickness of the calcification. OCT may be better, but I think from the angel, we only find that the calcification was moderate. So we can use IVUS first to check if the severe calcification, if predilation was failed. We also can check the OCT. But we also can use ROTA or IVR combined for the calcification treatment. I think maybe IVUS is the best choice. If the patient, maybe even though the renal function is okay, and echo, I mean, the EF value was also okay for this patient, but the left main is unprotected. I also think IVUS is the best choice.
Yeah, I agree with the option. You use IVUS guidance because it's a high-risk patient and actually it's impaired LV function. Considering reduced the contrast consumed, I also prefer IVUS to OCT guided this case. So, Doctor, can you show me what you have done now?
Yes. From today's angel, we find the severe stenosis at the osseous to proximal LAD. We also find the severe stenosis at the osseous circumflex. For this kind of situation, we use small balloon 2O balloon to predilate the LAD. We want to stop stop the anterior flow of the LAD when we use IVUS checking, and we use 2O balloon to predilate next. After wiring circumflex, yes, LAD and first diagonal. We also find a very interesting situation for this small diagonal. even though it's small, but it's very important for this case, just because the patient with old myocardial infarction of the inferior wall. So LAD and the diagonal is very important for this case. If we lose, the diagonal maybe will influence the whole left ventricular function in the future. So we use 3 wire, one in the LAD, one in the circumflex, and another in the diagonal. After pre-dilate LAD with a 2O balloon, next.
From this view, Dr. Ye, I noticed from this spider view, actually there is a very critical lesion at the ostimal LAD with reducted TIMI flow of LAD. So what's your first wire for rewiring LAD, and how to shape the wire tip to negotiate for this very challenging, angulated, and severe narrowing ostimal LAD?
Sometimes it's very difficult for this kind of view. This spider view, we cannot see the ostial LAD very clearly. Sometimes we can change it to the IO cranial or some AP quarter, so we can find the ostial LAD clearly. Okay, we can shape with one top. Give me a wire. I can show you. So it's very important for shape the tip of the wire when we wiring the LAD first. So I can show you first with one curve. If still failed, we will use a double curve.
Okay.
First curve based on the distal left mains diameter. Even though there is stenosis, okay, we can shape the tip of the wire with the diameter of the distal left main with one curve.
Can technician zoom in the camera to see, Doctor, how to shape the wire
we
tip?
can shape here. If we use a wire to negotiate the ostial LAD field, we can use a double curve. Double curve, another curve is, okay, 1 to 2 millimeter. Okay, just like this one. So we can negotiate successfully. So the first wire we can use a BMW wire, and the second choice, if BMW failed, we can use a run-through wire or cyan blue. Depends on. I don't want to use a hydrophilic wire, just because hydrophilic wire with the small tip, maybe it creates the dissection of force movement. So we can see we use one curve is a little difficult. Next. Oh, yes, we can see. Just we can see it can negotiate in the LAD very smoothly with a run-through wire. This is a run-through wire with one curve. So it's enough. If we still failed, okay, change the view to the RL cranial or AP quarter, we can find the ostial LAD clearly. So after pre-dilate with a 2O balloon, we check the IVUS. So next. So after that, we check the LAD IVUS. So Dr. Penta, would you show me the IVUS result of the LAD?
Okay, let me show the IVUS imaging. The first run, we check IVUS from the distal LAD to left main. Here, this point is the distal LAD. We can see the vessel is normal. The vessel diameter about 3.8. Then go and pull back about 7 millimeter. We can see a big septal will join LAD. So this point is the distal landing zone is over the distal septal about 7 millimeter. Then go and pull back, we can see calcification. Then go and pull back here, and the distal LAD vessel diameter about 3.4 millimeter. Then go and pull back, we can see the calcification angle is not more than 180%. Then go and pull back here, we can see the diagonal will join LAD. Here, this is the proximal LAD. The proximal LAD vessel diameter about 4 millimeter, and this point is a minimal lumen area. The area is just 1.6 millimeter square, and the plaque burden is about 85%. And here, the calcification angle is about 270 degrees. But after pre-dilation, we can see a crack. Then go pull back, this is the proximal LAD. And then here we can see circumflex will join LAD. Then go and pull back, this is a POC, and this is the distal left main. The distal left main area is just 5.1 millimeter square, and the plaque burden is more than 75%. Then go and pull back, this is the body left main. And the body left main vessel diameter about 5 millimeter square, 5 millimeter. Then go and pull back, this is the ostium left main. We measure the narrowness from the distal landing root to ostium left main is about 42 millimeter. And the distal landing root, from the distal landing root to the first diagonal, the narrowness is about 21 millimeter. From the distal landing root to ostium LAD, the narrowness is 31 millimeter. Okay, this is the LAD run. And the second run, we check IVUS from the diagonal to LAD. And the diagonal vessel is not normal. And we can see the calcified plaque. And the vessel diameter about 2.5 millimeter. Then go and pull back, we can see LAD guide wire. And this is the ostium diagonal. The ostium diagonal area is about 2.8 millimeter square, and the plaque burden is about 50%. The
Can you introduce the third round for the circumflex?
Yeah, the third one, we check IVUS from the distal circumflex to left main. The distal circumflex vessel is normal. And then go normal, vessel diameter about 2.7 millimeter. Then go and pull back, the vessel is not very large. And we can see attenuation plaque and some spotted calcium. Then go and pull back, we can see this point is the minimal lumen area. The area is just 2.1 millimeter square, and the plaque burden is about 72%. Then go on. Here we can see OM join LAD, and then go on. Here we can see a big OM will join circumflex. Then go on. Here we can see find the distal landing root, and here the lumen diameter about 3.2 millimeter. Then go on, pull back, we can see calcified plaque, and the calcification angle is about not more than 180 degrees. So go on, pull back. This is a proximal LAD.
Okay.
This is a calcification. Then go on. Here, this is the ostium circumflex, and here, this point, the area is just 2.1 millimeter square, and the plaque burden is more than 82%. We find the circumflex and the OM bifurcation is the distal landing root. From the distal landing root to ostium circumflex, the narrowness is about 28 millimeter. Okay, this is a baseline IVUS imaging.
Thank you, Dr. Pan, for your informative IVUS image. So according to the baseline IVUS imaging pullback from LAD, diagonal, and the circumflex, we noticed the proximal LAD, there is a superficial 270 calcification. But after 2 balloon predilation, there is a crack. So from this view, from this scenario, so I would have a question for Dr. Ye and your team. For this situation, will you use a special device for lesion prepare for these calcification lesions? You will only use NC or cutting balloon to the lesion prepare, or you will further use local ablation or even lister therapy for this superficial calcification. Actually, it's not so thick. From the IVUS, you can see it's a very, although 270-degree arc, but actually very, very thin. And also at 9 degree, there is a crack after 2 balloon predilation.
Yes.
So, Dr. Ye.
Yes, thank you very much. And I think lesion preparation before standing is very important for this kind of situation. Prepare with a large balloon, not very small balloon. Just for this case, from IVUS, we can find the reference diameter of the proximal LAD was 3.5. So we prepare with a 2.0 balloon is too small for standing. We cannot find it's maybe the stand can full expansion, even get some information from the 2O balloon predilation. So we want to use one-to-one NC balloon or cutting balloon. For this IVUS finding, we can see severe fibrous lesion, and with superficial calcification, I think maybe cutting balloon is better compared with NC balloon or conventional balloon or smaller balloon. So we think lesion preparation well is very, very important before standing, especially for this left main bifurcation lesion. This is my opinion.
Okay.
Thank you.
Okay, go ahead.
And so first we want to use 3-5 and cutting balloon to predilate the LAD, but we failed crossover just because the wire cross section at the maybe in the catheter. So we use 3O NC balloon to predilate previous first. After that, just because the wire crossover in the catheter, so pull back the circumflex wire. Then we use 3O NC balloon to predilate the proximal LAD lesion.
What's the pressure you up for
Tough,
the NC
tough,
balloon?
12.
Tough.
12. Okay.
We just want to make the lumen larger for
Okay.
the next cutting balloon predilate.
Okay.
After that, if we want to avoid the wire crossover in the cath lab, we just push the cutting balloon in the LAD, and we use another wire going to the circumflex to protect it, give another wire.
So in terms of the first diagonal, I noticed that you will use a wire to protect it.
Yes, yes.
Actually, from the IO cranial view, it's a moderate region, and also we have checked the IVUS. The plug burden is 50%. I think from this scenario, I think wire protect is enough. Yeah.
Yes. Even though we use 3O balloon to predilate first, we want to push the cutting balloon 3-5. It's very still difficult, just because maybe the wire still crossover at the proximal LAD.
Yeah, very.
So if we want to predilate with okay. So
you think because it's wire wrapped,
yes,
so maybe pull out the diagonal wire.
Oh, I think maybe it's still because of the
angulated and the calcification.
Yes, calcification. So we use test for wire. Test. Okay. Give me a spider view. Even though we cannot push the cutting balloon to the LAD, so we
use a body wire.
Okay. Not body wire. I want to protect the.
First, still protect.
Yes, still protect the diagonal. So even though we use test for wire. Okay, just because after predilate with 3O balloon, there is a lot of dissection at the proximal LAD. So it's a little difficult for wire. If we still failed with a cutting balloon predilate the LAD, so we just want to standing. Okay, test. A little difficult. Okay.
Will you take a picture to see after 3O balloon predilation?
Okay. Picture? Okay. We can find the dissection at the proximal. Yes. So after that, we use okay, for back the to stop the dissection enlargement. We use give me another wire, prepare. Just because the angulation was a little changed after that. Okay. After that, we still failed. We use a large curve. Okay. Test for Y. Test. Okay.
Yeah, still there is a high degree of radial stenosis at the proximal LAD, even after 3O NC balloon predilation.
Give me another wire. Show me the final angle. There is a dissection at the proximal part. If still failed, we can use a double channel test to negotiate the diagonal without touch
Mm.
the dissection. So prepare the double channel caster.
双腔尾导管准备。
So protect the big side branch is very important.
Yeah. Just because
So
there
for
is.
this severe stenosis at the main vessel,
Give me talker.
after 3O balloon predilation, there will be plaque shift
Yes.
and increase the difficulty for the rewiring the side branch. So as this scenario, I think dual lumen catheter will facilitate wiring the side branch.
So test.
I think there
Okay.
is a
Enough.
maybe there is dissection at the proximal AD.
That's
Yeah,
right. That's
yeah.
right. Why we feel very difficult.
Yeah.
Okay. Test. Okay. I know. It's a little difficult.
Will you go to another view, maybe IO cranial?
IO cranial, please.
Let's see. Then take a picture to see if there is severe dissection. More.
No. Just because there is a dissection, we cannot
Yeah.
find the true lumen of the ARD.
Yeah.
Oh no.
Maybe after take a picture, I think.
Sure. Test. Okay.
There is severe dissection.
Okay. Ready? Enough.
What do you see?
Dissection.
Yeah.
So we can
But I
use,
think the ostimal diagonal looks
even
okay.
okay. Yes,
Yeah.
I think.
Yeah.
Okay, we can standing.
We can stand in it.
Yes.
Yeah.
Okay, standing. Give me.
So
3
for the first stand, I think maybe 3.5, 20,
20,
29.
29. Yes.
Okay.
Enough.
So considering the total lesion length from the left main to the middle LED landing zoo is 42. So maybe we need a two stand.
Yes.
The first stand will put from the middle LED to the proximal LED will fully cover the ospinal diagonal.
Yeah.
Of course, we're also avoiding overlapping segment at the ostimal diagonal. Yeah.
Yes. We want to make 2 nails of the stand strata cover the osteo side branch. So this is 3.5. No, wait.
Oh. Still we need a lesion prepare. Yeah, looks.
Oh. Give me a 3.0 balloon.
Yeah. So from this view, I think lesion prepare is very important for this severe calcification.
Yes.
So we will do the NC balloon predilation again. If we still cannot advance the stent, doctor, will you change your strategy? Will you use a low ablation or a laser therapy
So
for
we
this
can use, yes, we can use double channel caster to make the body wire technique.
Okay.
So this is a 3.0 NC balloon predilate.
14.
14, 16. Okay, done. We can see the 3.0 NC balloon predilate very well.
Okay.
We cannot see.
Here, yeah.
Okay, go up.
There is a severe
14,
calcification.
16. Okay, done. I think it's okay.
Okay.
Go up. 14, 16. Okay, done.
Okay.
If we still failed, we can check the IVUS. If we find some man-made calcification nodule or nodular calcification, we also know what's the reason the stent cannot cross over.
Okay.
So if still failed, we can use a body wire technique. If still failed, we can use Gazina.
Gazilla, yeah.
Yes.
Extension guided catheter will give more support.
Yes.
In addition to EVU 3.5.
Yeah. This is 3.5.
29.
29.
Yeah.
No, stop. No. Stop.
Longer stem.
It's very interesting. Okay, give me another wire.
Oh,
Maybe double channel caster. Prepare for me.
So next step, doctor here will use dual lumen cassette to advance the second wire
So
to the distal LED. So body wire will give more support
yes, we
compared
use the
with
body
the
wire.
single wire. Yeah, because you can see from the angiogram actually
Okay.
the stack of the stand advancing into the mid LED is angulated with the calcification.
Yes.
Yeah.
I think there is a big angulation here,
Maybe
even though we cannot find that from the angel.
So because after balloon predilation, there is a dissection. So
Yes.
maybe body wire is safer. Yeah. You see a very good skill. Yeah. Yeah, you successfully wire the LED.
So after we use another wire
Yeah.
in the distal LED.
So what's this second wire? Still run through or
Runs through wire.
BMW runs through?
Runs through
Okay.
wire. Yes. Okay. So we
Another option, I think we can also use a super support wire,
yes.
like slim wire with a micro cassette to exchange
Yes.
slim wire.
Extra support wire is better compared
Yeah.
with a conventional wire.
Yeah.
For still failed.
Yeah.
Okay.
Nice. You nearly successful. Okay, good.
I'll pull back the
Angulated.
yes,
Okay, nice.
jet wire.
Yeah.
Okay.
So after body wire, doctor successfully advanced the stand
test
to the middle LED.
Okay, just okay. Okay, give me AP spider view. So first the stand will cross over the side range Austin.
Yeah, the fully cover the first diagonal. Yeah.
Okay, test.
Just at the.
Okay, pull it back.
Pull back a little. Yeah.
Okay, test. Okay, give me a IO cranial.
To check the distal position.
Yes, the distal landing zone is.
Yeah.
It's also very important for this case. Yeah. See it?
Yeah, it's good. I think it's good. Yeah. So the 3.520 nice then fully cover from the middle AD to the optimal AD. Yeah. Looks expansion is good from at least from the angel.
Okay, done. See it? Fine. Okay. Done.
Oh. Looks we lost the diagonal. Yeah.
No, seemingly still there. Still there. Yes. Yes.
Maybe give some nitro. Is there? Okay.
No symptom of the patient. We can check the spider view.
Yeah.
RO cranial, we cannot see the diagonal clearly.
The patient is okay. Hemodynamic is stable, and the ECG there is no change. Maybe. Yeah, TME1 flow. Yeah.
Okay, no problem.
Maybe give some nitro, then
nitro.
Go to C.
And give me another wire.
哪根螺丝？来根新的吧，来根新的了。
And just because the patient was okay, we want to negotiate the side branch first before we treat the distal left main patient lesion. If needs more time, we can treat the distal left main first. Then
maybe I think after GTN injection, maybe the flow will be recovered better.
Yes,
then we
hope
can
so.
Try to rewire the side branch.
We hope so. Give me talker.
Because from the IVUS, it's a 2.5 side branch.
Yeah,
it's not so small.
Yeah.
We
it's very
should rescue this side branch.
Okay. Okay.
So what why Dr. Ye
Still
for
run
the
through.
run through, still run
Yes,
through?
run
Okay.
through. Just because there is a small dissection at the proximal part of AD, so it's a little difficult to wire in
Yeah.
the AD from the true lumen.
Maybe
Sometimes we standing first, then we find it. Okay. Okay. Give me a test. Oh no. Okay, test. Okay, no.
yeah, the flow is better, I think,
Yes.
after GDN injection.
Yes.
So this
Mhm.
scenario, I think maybe dual lumen catheter will give more support
Yes, I think
for the
so.
rewiring. Yeah.
No, I don't think it's for time to find the osteo diagonal. So we can treat the, there is a big angulation. I
Yeah.
think so. Ah. Give it, Sydney, we
Sydney?
find the flow is better. Okay, we can, okay, done. Should we treat this left main bifurcation first, then?
Yeah, I fully agree because at this time I think the patient hemodynamic is stable and the
Yes,
ECG no
yes.
change.
Yes.
Actually, after coronary injection GTN, the flow is better. I think maybe we can treat left main first. Yeah.
Yes, I think so. And
in terms of the circumflex, according to the IVUS measurement, the lesion length is 15. Yeah, I think so. And also in terms of optimal circumflex, IVUS show the very eccentric, very fibric burdens. Maybe we still need a predilation.
show me the final angel.
Mm.
Yes. Previous one. Previous one. Okay.
Yeah.
So could you tell me the standard size based on the IVUS finding? IVUS can tell me
3.0.
3.0.
Vessel is
3.0,
3.0. Yeah.
26.
Yeah.
30 maybe.
Better.
Yeah.
30 may be better. Okay, give me 3.0 30.
Okay. Will you do the lesion prepare? Because
Okay. Yeah.
from
Yeah.
the
Yeah. 3.0.
3.0 NC balloon.
3.0 NC balloon, please.
Yeah.
Give me 3.0 NC balloon.
Considering the optimal circumflex is a very eccentric fibric plug burdens.
Yes.
I think before
yes.
we put a stent, we can still use the NC balloon to do the lesion prepare.
Yes. Yeah.
LED.
No, circumflex.
Mm. So it's a typical high-risk PCIs, or the inferior MI with the distal left main. So with the IVP support, so when we treated this high-risk patient, circulated support can give us quite a long time to treat this challenger case. So
Yes.
first, we will treat this distal left main with a DK crush. Then we will do the angio again to evaluate the diagonal and
Okay, go
and
on.
make a decision to rescue the first diagonal. Yeah.
Okay, done. So for this very complex bifurcation with a very sharp angulation at the osteo, circumflex and osteo side branch, so down, it's very important to use the IVUS protection, IBP protection before procedure.
Yeah.
So, yes, we think IBP is very, very necessary for this kind of issue. Go up to 14.
14.
Okay, done.
Mm.
Still on the expansion, we use higher pressure to predilate the osteo circumflex. Okay, done. Up. 14, 16. Okay, done. This is a 3.0 NC balloon, predilate the circumflex lesion. After that, we can check. Okay,
Okay.
give me test. If there is no dissection and the flow is okay, okay,
Okay.
we can standing. With a 3.5 NC balloon.
3.0 NC balloon.
4.0 balloon. just because we want to stand with a full O stand covered from the proximal AD to the left main. So based on the IVUS finding, we can see the reference diameter of the proximal AD was 4.0 and the left main was 4.5. Is that right?
5.0.
5.0. Okay. Left main reference diameter is 5.0. Okay.
So for the side branch, then you will choose a 3.0 by 29,
Yeah.
and with a 4 balloon at the proximal AD to the left main,
Yeah.
which
yeah.
will be used to do the crush,
Yeah.
balloon crush.
Yeah. You can
Okay,
see the
nice.
band across of the
Yeah.
osteo circumflex very easily compared with the first stand proximal AD.
Yeah.
This is 4.0 12.
12.
NC balloon.
NC balloon. Yeah.
8.
8? Okay, 8. Okay.
It's a little short.
Yes,
Oh,
a
it's
little
okay.
short. It's okay.
Which will be used to do the balloon crush after
Yeah.
circumflex standing. Yeah.
This is 408.
Yeah.
Okay.
So in terms of a decay crush, I think Dr. Ye, you are the master. And what's you were protrusion into the
Okay.
left main for the circumflex stand?
1 to 2 millimeter if it is possible from
Yeah.
the angle, we can find it clearly. Okay, put it back. Yes.
For distal, you were just before the first obvious marginal
Yes.
branch. Yeah.
Yes. See? Okay.
Maybe still a little proximal. What do you think?
Yes. Okay. How to think with the position?
Yeah, the distal landing zone looks
A little distal?
Will you go to AP Kodo
AP
to
code,
check the
AP code.
distal?
I
Because
think the stand was a little longer.
yeah, I think
So 26 is better, I think so.
yeah,
Test.
maybe I think maybe a little proximal because distal there is no landing zone. Yeah, what do you
We
think?
can change on those. Okay, wait.
26?
26, yes.
Okay.
26.
26.
Give me 26.
So 29 is a little now longer.
28 maybe better.
Yeah. 26.
26. That's because the landing zoom is very important for the circumflex. There is a low normal segment of the circumflex. We can find the landing zoom just because the middle part of the circumflex was landing zoom with black burden less than 50%.
Yeah.
So we can
Good.
wait a moment. Okay, test. So lead the back. Okay. Still need the back.
Yeah, I think so. Still need back. You should confirm fully cover the ostimal circumflex. Yeah.
Okay.
Yeah. Yeah, it's good. I think.
So just the part of the stand.
It's okay.
Proximal is okay.
Okay.
AP quarter.
So we need to view to confirm the stand location. Maybe
Distal
a
part.
little distal. Yeah.
Yes, a little distal. Okay, test for. Okay, go up.
Okay, 3026 stand.
Nice.
Yeah.
9.
This is the first step
10.
of the decay crutch. Side branch standing.
Okay, done.
Fully cover the ostimal circumflex. At the
Give me
same
maybe
time, there is an
spider
NC
wheel.
balloon at the main vessel.
Side view. Yes. After that, we make sure the side branch stand optimization with
A stand balloon.
Yes,
Okay.
stand balloon. Put it back.
Yeah.
Yes.
You use
go
the
up.
stand balloon to do the post dilation.
Yes.
At high pressure.
12, 14.
14.
Okay, done.
Looks good, huh?
Okay. So side branch ostium optimization is very important before we perform the first crush.
Okay. So after side branch standing and the side branch optimization, we will do the angiogram
Yes.
to check there is no distal edges dissection. Then we will do the
Yeah,
do the
okay.
balloon crush.
Okay. Okay. We can see the stand for expansion.
Okay, good.
Okay. No dissection of the distal of the stand segment, 那个 H.
Go to AP caudal.
Okay, epicorder.
Looks good.
Okay.
Okay.
Okay. We perform the first crush with a 4-0 balloon.
Okay.
Spider view. Okay. Inflation. Inflation.
The short balloon.
Okay,
Yeah, there is
done. Just because we for the first crush, the NC balloon should be longer
yeah.
to avoid the slip during the first crush. Okay, well, give me. Okay, inflation. 14, 16.
Yeah, nice.
Okay, no,
Still little sleep. Yeah.
Okay.
Because there is a severe narrowing at the distal left main.
Yes.
Yeah.
Yes.
Maybe. Yeah.
Okay,
Good.
go up, go up.
Gently, slowly. Good.
12,
Nice. Nice.
14, 16.
Good.
Okay.
Okay.
Done.
Nice.
It's better.
Yeah. Fully crush.
Yes. So we
So
can.
we already checked the IVUS after balloon crush to
Sure.
see it's a fully
Okay,
crush.
give me
It's
IVUS.
very important.
Yes.
Otherwise, maybe there will be a difficulty for the first rewiring the side branch. So that's why when we do the balloon crush, the balloon size is very important. The balloon size should according to the proximal reference vessels to achieve the fully crush. So let's see what happened after balloon crush. There will be 2 layers of the stent structure at the distal left main. Yeah. And also for the balloon crush, we'll open the stent seal of the circumflex and facilitate the first rewiring from
Okay,
the
IVUS.
yeah.
Okay, I will pull back the proximal LED.
Yes.
LED, yeah.
Is the POC, and we can see 2 stand.
Yes.
2
This is
stand
still
here.
LED,
The crush
yeah.
is good. Yeah.
再准备根导丝。
Okay, I will stop.
Okay. Could you measure?
I think we have achieved a good balloon crush result.
Yes.
Dr.
I
Pan?
think so. Give me another wire.
So for the DK crush, for the first rewiring, so Dr. Ye, how to confirm it's from the proximal cell?
Yes, from the angel we can find. We use jet wire tactic.
Okay.
So first, circumflex wire still maintains there, just because there is a marker of the proximal part of the osteo circumflex. So we can rewire just nearby the jet wire. That's from the angel guidance. If we perform with IVUS guiding, it's very useful, and it's very accurate.
Okay.
Make sure the wire from the proximal part of the circumflex.
Okay.
So we
Yeah.
perform this just from the procedure. Give me talk.
Okay.
So first, we perform insert the wire into the LED. There is smoothly. Okay, we can pull back. Use a pullback technique. So this is LED, and make sure the tip of the wire according.
Yes.
Okay, pull back.
This is the first key point of DK crush.
Yes.
First rewire we should from the proximal cell, avoiding distal access. because for the wider this angle bifurcation, if we from the distal cell, maybe the wire will go on beyond under the stem structure. So that's why we use the first jet wire as a marker and use the third wire to rewind the circumflex.
Mhm.
So for the wiring the side branch, what's your first workhorse wire? Still run through or
BMW first.
BMW?
Sometimes we use run through. And we don't want to use hydrophilic wire for the first rewiring, just because the hydrophilic wire feedback is very, very poor if the wire go under the stem strut. But from the BMW wire or run through wire is better. We can feeling the feedback from the finger. Okay, give me, okay, test, just a test. There is some, okay, some a big angulation. Sometimes we make.
Yeah, you successfully.
I don't know. The wire position is okay. We can check with.
Check
okay.
the IVUS. Yeah,
Yes, check
I
with
think
the
it's
IVUS.
from the proximal to mid cell, not distal. Yeah, from
distal.
the angel, you can see the wire
No,
is.
Don't touch. Okay.
You can take.
Another feeling is just we push the wire. We cannot find any resistance. Yes.
Which means it's from the proximal to mid cell.
LED wire. Okay.
Yeah.
I put it back. No, this is the complex wire. This is LED wire. So we recheck the IVUS
to see
from the LED.
To see the wiring is from the proximal cell.
Yes, it's a key point of the IVUS guidance.
Yeah. So not only from the angel, but also from the IVUS image, we can confirm the first rewiring of the circumflex is from the proximal cell.
Yeah.
That's very important for decay crush, especially for left main bifurcation. Yeah. So Dr. Pan, are you ready?
I'm ready.
No, I don't know the reason why we cannot push the. Is any resistance at the proximal part of the LED? We cannot push the. Okay, give me 35 NC balloon or 40 NC balloon. Give me. I don't know what's the reason.
Yeah.
Yes, just because the wire still the same wire in the LED, we cannot.
Yeah, but anyway, I think from the angel, I think it's from the proximal cell.
Yes.
So in terms of the next step of decay crush, first kissing balloon inflation, what's the balloon size?
Deflection.
For the diagonal, you are according to the proximal reference.
Yeah.
You will choose 3.0.
Yes, 3.0.
Okay, prepare the 3.0 NC balloon.
NC balloon.
New one.
New one.
Give me longer. Give me longer.
Short.
Okay, good.
Okay, go up.
Good.
Go up.
Go up.
Turn off.
Okay, enough. Okay, down. No, enough. Okay, go up.
Good, nice.
Okay, down.
Okay.
What's the reason? Just because the angulation.
I think it's angulated. Yeah.
Yeah. It's
now
better.
It smoothly looks, huh?
It's better. So we check the IVUS.
Check the IVUS. So maybe we have 5 minutes left.
Okay.
That's okay, I think. I think it's a very important step for the decay crush.
Yes.
Precisely, accurately perform decay crush.
Yeah.
This is a typical challenger case. Chip case, yeah.
Okay, it's better.
Yeah, that.
IVUS.
Yeah,
Yes.
okay. I will pull back. Yeah, this is
okay.
Austin LED. The guard wire.
Yes, I just pushed a little distal. Okay.
Okay,
yeah.
okay. Pull back.
Yes.
This is Austin LED. Pull back. This is POC. And we can see the guide wire.
I think it's from proximal.
Yeah,
Yeah.
sure, it's passing through the proximus here.
Yeah.
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 Good.
Okay, I will stop.
Okay, stop.
So Dr. Ye will perform next step DK question for first casing, and Dr. Pan, can you introduce to the audience of online how
This
to
is circumflex.
how to
Jet wire.
precise define the proximal access?
Okay,
Give me 4
我
O
们
balloon.
must find the
3
2
O balloon.
points.
4.0高压，
Uh,
来个3.0的新高压，
No problem.
新的。
没关系。No problem. No problem.
but first, we must find
The
the
4O.
distal point of the
这是新的3.0新的。
This is 4 O balloon. Deflection.
you can find
Deflection. Okay, 3 O NC balloon. Give me. Three O NC balloon.
So still you use 4O balloon for LED
Yes.
and the 3O balloon for circumflex
Yes.
to perform first casing. Yeah.
Yes. So this is a 3O NC balloon to push
Yeah.
into the circumflex. If we find the revolve position is good, okay, we can find the ballooning crossover to the circumflex. It was easier.
I think that will be easier.
No. Okay.
Yes.
Nice.
Okay. Graph
12,
12, 14,
14,
16.
16.
Okay, done.
Professor. Yeah, we
Yes.
have still have 15 minutes.
Okay, 15 minutes.
Yeah.
Okay,
You
we
should
have
get
enough.
up.
Okay,
Okay.
graph.
Sure.
Graph. 14, 16. 16.
Okay.
Okay, done. So, okay, graph.
14.
Professor. Yeah, we
Okay,
have a
done.
mistake. We have
So-
just 5 minutes.
5 minutes.
Yeah.
Okay, 5 minutes. Okay.
Before first casing, you will use the NC balloon sequentially post-dilate circumflex
Yeah.
and the LED. Yeah.
Yes. Circumflex first. 14, 16, 18. 18. Okay. Done. Okay, LED. 14,
12,
16, 14. Okay, done.
Okay.
Okay, kissing.
When do the kissing, you will only minimal protruding into the main vessel proximal part.
Okay, done.
Looks nice, huh?
Yes. It's better.
Then after first kissing, the next step is the main vessel standing. So what's
Yes.
the main vessel size? In terms of diameter, I think 4 is enough. And
4.
how about the length?
Show me the previous angle. We'll check with the balloon length. RL cranial. We use stand
15?
balloon. Stand balloon. Stand balloon.
Or maybe another method is you to use IVUS check the lesion length.
Yes, if we have time.
Yeah.
Show me the RL cranial. RL cranial. So the 第三幅第一行第三幅。造影回放。Okay, no. Stand balloon to measure the lesion length of the osteal AD to the stand side. Okay, here.
Yeah.
This is
29. 29.
Okay.
Maybe 18. What do you think?
Okay, 18 is
18.
enough.
18, no,
18.
18.
18.
Then prepare the 4.5 hot balloon.
Yes. For balloon, hot balloon.
4.5.
No, 4.5. 4.5 or
Port 4
Port
5
balloon.
4 5.
5.
Yeah.
Angulated.
Yes.
Very
Angulation
angulated.
is very, very sharp.
Yeah.
This is. Uh, this is circumflex.
So you will make the guiding cassette coaxial. Yeah. Still there is a
Yeah.
difficulty. Yeah. Diff engage.
Oh, yeah.
Okay.
A nice
better.
angulated lesion.
Yes.
Calcified.
Yes. No.
So you
Okay, epicranial or ariocranial.
you will put the second wire at the LTAC root as a
Yes.
marker to
Yes.
avoid guided deep engage,
Yes. Yes.
and then also mark the ostimal left man.
Ariocranial. Yes.
So how to position the ostium left man? So Dr. Yi,
Yes.
what's your
It's,
tips? Can you tell us?
yes. From the angel, we want to perform the full coverage of the osteo. Oh, no. We cannot see the distal part of the stem. Epicranial. Epicranial. A little larger. No, we cannot see it. Okay. Epicorder. We can so make sure the two standard full cover.
Overlapping, yeah.
Overlapping, yes. Are you quarter? Are you quarter?
IO corner.
右组。
对。
右组。No, it's little.
I see.
Overlap.
Definitely overlap already.
Oh, we can see the angulation. It is.
Yeah.
How about the osteo?
Not sure. I think still we need a cranial view
Epicranial. Epicranial.
to check the stem is fully covered the ostimal left man. Yeah.
Yeah. Okay.
We use a floppy wire as a mark. What do you think?
I think a little back is better.
Yeah, I think so. Because for the distal part, I think it's long enough.
Yes.
We have fully overlap, at least 3
Test.
millimeter.
Okay. Seen it. Okay. Still little back. I think it's better.
Yeah. Maybe 1 millimeter.
Just test. Okay. Okay. No. Okay, seen it. Okay.
I think here we have definitely fully covered.
Yes. I need to push a little back. Yes, test for a while. Yes.
I think now.
Ariocranial. Okay, show the distal part of the
Cranial.
Ariocorder.
Ariocorder.
We don't need the
Only
contrast.
seen it, yeah.
Yes.
Okay.
I think it's fully covered.
Yes.
Overlap.
Up.
Up.
12.
Yeah. Okay, done.
Good.
Yes.
Good stem expansion.
Yes, I think standard was for expansion. Okay. After we check the angle, we use a pot balloon to perform the pot first before we rewind to the circumflex. Okay.
Ready for angel?
Okay.
Nice.
Still on the expansion of the first
Yeah.
stand. Yes.
Yeah.
We will perform the post-dilation after that.
Okay.
Okay, give me pot balloon. So we can zoom the pot balloon here. So the length of the balloon was very short and the shoulder was very short compared with the NC balloon. So what's the size of the pot balloon?
4.5.
4.5?
5, yes.
The length was
8.
8.
What is
Okay.
short balloon?
Okay.
How to precisely position the pot balloon?
First part, we don't want to touch the cranial tip.
Okay.
So, angel. Okay.
What's the future of the pot balloon? The shoulder is very, very short. Huh?
Okay, go on. Yeah. after inflation, we make the cine, we can find, okay, the shoulder was very short. Okay,
less than 0.5 millimeter.
yeah. Just go up.